Welcome to Pediatric Case Review. Today's lecture covers pneumonia in children, a common and serious respiratory infection. Our purpose is to master recognition, diagnosis, and management of pediatric pneumonia through case-based learning. We will explore clinical presentation, examination findings, pathophysiology, investigations, treatment approaches, and potential complications. Each topic will be presented as a multiple-choice question followed by detailed explanation. This interactive format helps consolidate your clinical decision-making skills. Let's begin our comprehensive review of pneumonia in children. A 6-month-old infant presents to the emergency department with fever of 39 degrees Celsius, productive cough, poor feeding, and irritability. The respiratory rate is 70 breaths per minute. Which single sign most strongly suggests pneumonia in this infant? Option A, tachypnea. Option B, hoarse voice. Option C, conjunctivitis. Option D, ear tugging. Take a moment to consider the case and select your answer. The correct answer is A, tachypnea. Age-specific tachypnea is the most sensitive clinical indicator of pneumonia in infants and young children. For infants under 12 months, respiratory rate above 60 breaths per minute is considered tachypnea. This sign reflects increased work of breathing due to alveolar consolidation. Hoarse voice suggests laryngeal involvement seen in croup. Conjunctivitis indicates viral upper respiratory infection. Ear tugging typically points to otitis media. Remember, tachypnea is your key clinical sign for suspected pneumonia in young infants. A 9-year-old child presents with gradual onset of low-grade fever, headache, and dry cough over 5 days. Several classmates have similar symptoms. On examination, the child appears well but has diffuse crackles bilaterally. Which clinical pattern fits best? Option A, atypical pneumonia. Option B, croup. Option C, bronchiolitis. Option D, pertussis. Consider the age, symptoms, and epidemiology before answering. The correct answer is A, atypical pneumonia. School-aged children and adolescents commonly develop atypical pneumonia caused by organisms like Mycoplasma pneumoniae, Chlamydophila pneumoniae, or viruses. The gradual onset, minimal fever, dry cough, and extrapulmonary symptoms like headache are characteristic. Clustering of cases in schools suggests person-to-person transmission. Croup affects younger children with barking cough. Bronchiolitis occurs in infants. Pertussis presents with paroxysmal cough and whooping. Recognizing this pattern guides appropriate antibiotic selection, favoring macrolides over beta-lactams. A 2-year-old child presents with fever, cough, chest indrawing, and nasal flaring. On examination, you notice central cyanosis of the lips and tongue. Which single sign most strongly indicates severe disease requiring urgent intervention? Option A, central cyanosis. Option B, mild subcostal retractions. Option C, diffuse wheeze. Option D, afebrile state. Think about which finding represents the greatest physiologic compromise. The correct answer is A, central cyanosis. Central cyanosis indicates significant hypoxemia with oxygen saturation typically below 85%. This is a danger sign requiring immediate oxygen therapy and hospital admission. Cyanosis means inadequate oxygenation of blood, threatening organ function. Mild subcostal retractions alone do not define severe disease. Diffuse wheeze suggests reactive airway disease rather than consolidation. Being afebrile does not indicate severity. Always assess for central cyanosis in children with respiratory distress, as it signals critical hypoxemia demanding urgent intervention. A 5-year-old presents with fever of 38.5 degrees Celsius for 3 days. Examination of the right lower chest reveals decreased air entry, tubular breath sounds, and dullness to percussion. Which finding best supports lobar consolidation? Option A, bronchial breath sounds. Option B, diffuse wheeze. Option C, transmitted upper airway noise. Option D, normal percussion. Consider which auscultatory finding indicates alveolar filling. The correct answer is A, bronchial breath sounds. Bronchial or tubular breath sounds heard over peripheral lung fields indicate consolidation. Normally, these harsh sounds are heard only over the trachea. When alveoli fill with inflammatory exudate, sound transmission changes, producing bronchial quality. Accompanying signs include dullness to percussion and decreased air entry. Diffuse wheeze suggests airway narrowing from asthma or bronchiolitis. Transmitted noise occurs with upper airway congestion. Normal percussion argues against consolidation. Recognizing bronchial breathing helps confirm pneumonia clinically. A child diagnosed with pneumonia develops fast breathing and low oxygen saturation despite normal airway patency. What is the primary cause of hypoxemia in pneumonia? Option A, ventilation perfusion mismatch from alveolar consolidation. Option B, low hemoglobin concentration. Option C, central hypoventilation from brainstem depression. Option D, airway hyperreactivity with bronchospasm. Think about the underlying pathophysiology of alveolar disease. The correct answer is A, ventilation perfusion mismatch. In pneumonia, alveoli fill with inflammatory cells, fluid, and bacteria, preventing gas exchange while blood flow continues. This creates ventilation perfusion mismatch or shunt physiology. Deoxygenated blood passes through non-ventilated alveoli without being oxygenated. The body compensates with tachypnea, but hypoxemia persists. Anemia reduces oxygen carrying capacity, but is not the primary cause here. Central hypoventilation causes hypoventilation, not typical in pneumonia. Bronchospasm causes wheezing and airflow limitation. Understanding ventilation perfusion mismatch explains why oxygen therapy is critical. A 3-year-old child presents with mild suspected bacterial pneumonia. The child is stable, drinking well, and can be managed as an outpatient. Which test is indicated today? Option A, no imaging. Clinical diagnosis is sufficient. Option B, chest radiograph. Option C, chest computed tomography scan. Option D, arterial blood gas analysis. Consider current guidelines for uncomplicated community-acquired pneumonia. The correct answer is A, no imaging. Clinical diagnosis. Current guidelines recommend against routine chest radiography in uncomplicated outpatient pneumonia. Clinical diagnosis based on fever, cough, tachypnea, and focal chest findings is sufficient to start treatment. Radiography does not change management in straightforward cases and exposes children to radiation. Imaging is reserved for severe disease, hospitalization, failed outpatient therapy, or uncertain diagnosis. Computed tomography involves excessive radiation. Arterial blood gas is invasive and unnecessary in stable patients. Trust your clinical assessment. An infant presents with clinical signs and symptoms concerning for pneumonia. You need to assess oxygenation status at the bedside. Which test best detects low oxygen levels? Option A, pulse oximetry. Option B, capillary refill time. Option C, chest radiograph. Option D, complete blood count. Think about which test directly measures oxygen saturation non-invasively. The correct answer is A, pulse oximetry. Pulse oximetry is the gold standard bedside tool for detecting hypoxemia. It provides immediate, continuous, non-invasive measurement of oxygen saturation. Values below 92% in children indicate hypoxemia requiring supplemental oxygen. This simple test guides triage decisions, oxygen therapy titration, and monitoring response to treatment. Capillary refill assesses perfusion, not oxygenation. Chest radiograph shows infiltrates, but not oxygen levels. Complete blood count reveals infection markers, but not hypoxemia. Always measure pulse oximetry in suspected pneumonia. A hospitalized child presents with severe pneumonia, high fever, toxic appearance, and respiratory distress. Which investigation is recommended before starting antibiotics? Option A, blood cultures before antibiotics. Option B, routine outpatient sputum culture. Option C, screening chest computed tomography scan. Option D, viral serology panel for retrospective diagnosis. Consider which test guides antibiotic therapy in hospitalized patients. The correct answer is A, blood cultures before antibiotics. In severe or complicated pneumonia requiring hospitalization, obtain blood cultures before starting antibiotics whenever feasible. Blood cultures identify the causative organism in 10 to 30% of bacteremic pneumonia cases, allowing targeted antibiotic therapy. Sputum cultures are difficult to obtain in young children and often contaminated with oral flora. Computed tomography is not a screening tool. Viral serology provides retrospective diagnosis, not acute management guidance. Remember, cultures before antibiotics optimize antimicrobial stewardship. A 2-year-old immunized child presents with presumed bacterial community-acquired pneumonia suitable for outpatient management. Which is the best first-line oral antibiotic? Option A, amoxicillin. Option B, azithromycin. Option C, ceftriaxone injection. Option D, oseltamivir. Consider the most common bacterial pathogen and recommended empiric therapy. The correct answer is A, amoxicillin. Amoxicillin is the first-line outpatient antibiotic for bacterial pneumonia in children, targeting Streptococcus pneumoniae, the most common bacterial cause. Recommended dose is 80 to 90 milligrams per kilogram per day divided twice daily for 5 to 7 days. High-dose amoxicillin overcomes pneumococcal resistance. Azithromycin is reserved for atypical pneumonia or penicillin allergy. Ceftriaxone is parenteral therapy for severe disease. Oseltamivir treats influenza, not bacterial pneumonia. Always choose amoxicillin first unless specific contraindications exist. A 12-year-old presents with gradual onset cough, minimal fever, and interstitial pattern on chest radiograph. Atypical pneumonia is suspected. Which is the most appropriate antibiotic? Option A, azithromycin. Option B, amoxicillin. Option C, vancomycin. Option D, oseltamivir. Think about which antibiotic covers atypical organisms effectively. The correct answer is A, azithromycin. Macrolide antibiotics like azithromycin are the drugs of choice for atypical pneumonia caused by Mycoplasma pneumoniae, Chlamydophila pneumoniae, or Legionella species. These organisms lack cell walls, making beta-lactams like amoxicillin ineffective. Azithromycin provides convenient once-daily dosing for 5 days and excellent tissue penetration. Vancomycin targets resistant gram-positive bacteria, not indicated here. Oseltamivir is antiviral therapy. Recognizing atypical pneumonia patterns in school-age children ensures appropriate macrolide therapy. An infant with pneumonia presents with oxygen saturation of 89% and poor feeding. What is the next best step in management? Option A, give oxygen and support hydration as needed. Option B, start cough suppressant medication. Option C, discharge home with oral antibiotics only. Option D, delay oxygen until imaging is completed. Consider the immediate priorities in hypoxemic infants. The correct answer is A, oxygen and supportive care. Hypoxemia with saturation below 92% requires immediate supplemental oxygen to prevent organ damage. Supportive care includes maintaining hydration, either oral or intravenous if unable to feed, antipyretics for fever control, and nutritional support. Cough suppressants are contraindicated as coughing clears secretions. Hypoxemic infants cannot be managed outpatient and require hospitalization. Never delay oxygen therapy waiting for diagnostics. Oxygen is life-saving, and supportive measures optimize recovery alongside antibiotics. A child has been on antibiotics for 72 hours but develops worsening fever and pleuritic chest pain. Examination reveals dullness and reduced breath sounds on one side. What is the next best investigation? Option A, chest ultrasound. Option B, increase antibiotic dose only. Option C, chest computed tomography as first-line imaging. Option D, bronchoscopy. Think about the suspected complication and appropriate imaging. The correct answer is A, chest ultrasound. Persistent fever with pleuritic pain and focal dullness suggests parapneumonic effusion or empyema. Chest ultrasound is the preferred investigation, confirming fluid presence, characterizing septations, and guiding drainage decisions without radiation exposure. Ultrasound is more sensitive than computed tomography for detecting septations, which determine if chest tube drainage or fibrinolytics are needed. Simply increasing antibiotics without drainage is insufficient. Computed tomography involves radiation and is reserved for surgical planning. Bronchoscopy evaluates airways, not pleural space. Always use ultrasound first for suspected effusions. Join the Pediatric Case review community on Patreon and take your learning to the next level. Our community provides all educational videos organized by organ system, making it easy to access specific topics whenever you need them. Every presentation used in our videos is available for download as high-quality images, so you can read, review, and practice all questions at your own pace. This comprehensive resource helps you build clinical knowledge systematically. For details on subscription options and how to join, please comment below on this post, and we will message you directly with all the information. We have completed our comprehensive review of pneumonia in children. Key takeaways include: recognize age-specific tachypnea as the cardinal sign, assess severity using danger signs like central cyanosis, understand ventilation-perfusion mismatch pathophysiology, investigate wisely without routine imaging in uncomplicated cases, treat empirically with amoxicillin for typical pneumonia and azithromycin for atypical patterns, and watch for complications like parapneumonic effusion. Follow Pediatric Case Review for more evidence-based medical education presentations. If you have any questions or topics you would like covered, please comment below. Thank you for learning with us today.